Great. All right, so lovely to see many of you. And for those of you that don't know me, my name is Megan Crane. I am the part of the OHA Oregon Health Authority Suicide Prevention Team. And my position is the Zero Suicide and Health Systems Coordinator. So today, let me just get the screen shared here, make sure everyone can see that. Can you see my screen?
Yes.
Great. Okay, so I think what we're going to do is please, we'll wait to take questions until the end and see how much time we have, but please feel free to put your questions in the chat in case I'm not able to address them. I have them so that we can address them after the meeting. This presentation is going to be a very narrow snapshot of data in Oregon. So I've been asked to present data, that the Oregon Health Authority Public Health Division Injury and Violence Prevention Program has included in the 2021 Youth Suicide Intervention and Prevention Plan Annual Report. So this is a report, and what Jill and Shanda will be talking about is currently being finalized for publication. So this is not all the data in that report. I also just really want to acknowledge one reason we wait so long for finalized suicide data is so that we can have the comparison to other states in the nation. And that's something that's very important to partners and legislators, with this being a legislative facing report. This data does not highlight other data sources such as the Student Health Survey, qualitative and focus group data, Big River programming data, and the amazing work being done around the state by each of you in terms of training programs, awareness activities, and suicide prevention work. Some of this data may be challenging to hear. I really encourage you to step away if you're not in a place to hear this right now. These slides will be made available for you to follow up. So the links in here and the materials you can access. And again, as at the beginning of the meeting, if you do need support, during the meeting, I'll call out some individuals I think are okay to do that for: Annette, Gally, Ryan, Jill, Shanda. Please reach out. And again, if you cannot sit and hear this data, that's okay, and you don't need to. So a note about data systems quickly is that research and data science are centered around the fallacy that data is objective. This is math, these are facts, numbers don't lie. And while the tools of statistics and data science don't carry inherent biases towards a worldview or group, as soon as people get involved, they start making choices that, if examined, reinforce their own perspectives in a way they affect the data outcomes, and by extension, the decisions and actions based on them. So for example, how are race and ethnicity categories defined? What are we losing by having broad categories like white, Latinx, and Black? Are we asking individuals or providers to categorize individuals? What is the willingness of communities to provide information due to their mistrust of systems where they have experienced oppression and racism? So an example of this would be our emergency medical support responders. 1/4 of overdose responses do not include race and ethnicity data. And when asked why, those responders don't feel comfortable asking, they don't know how to ask. What if they're dealing with a patient, supporting a patient who's unconscious, and they don't want to assign because they can't ask? So these are the realities of some of the data issues that we're dealing with that I just wanted to name. We also need to do a much better job of this data looking at intersectionality. So the acknowledgement that everyone has their own unique experiences of discrimination and oppression. And then we must consider everything and anything that can marginalize people, such as gender, race, class, sexual orientation, physical ability, among many others. I did just want to call out House Bill 3159 that was passed in 2021. We're anticipating rulemaking on this bill will happen this spring, followed by development of a data collection system, really to collect patient data much more broader than we have been, and for Oregon Health Authority to create a database for storing and analyzing that data. I also want to recognize that this is not a short-term project. The tentative timeline to build the database is between 2023 and 2025, with piloting of the system in 2024. One more note before I get started here. You may hear me use the term small numbers in this presentation. I want to emphasize that any suicide is too many, and I agree with that. Any individual that dies by suicide deserves the dignity to be included, to show value of their life, and to be considered in informing prevention efforts. As we've discussed, we need to do work to improve our data systems and address oppression and inequalities that permeate our systems, institutions, and societies. Small numbers is a statistical term we use that's associated when we have estimates of lower statistical credibility and an elevated risk of privacy breach. Estimates with few cases tend to be unstable and prone to misinterpretation. For example, it can be hard to answer questions around if certain Oregon youth suicide rates by race and ethnicity are increasing due to the low number of deaths per year. This is where we need to rely on regional, national trends, our communities, and regardless of counts, ensure these populations are considered in suicide prevention, intervention, and postvention activities. Just because we don't have the data does not mean that the data does not exist and that there are communities that need that support. So thank you for bearing with me as I shared all of that, and let's get into some of the data. We'll get started with our emergency department and urgent care center data. So this is data through our Oregon electronic surveillance system for early notification of community-based epidemics, or what we refer to as ESSENCE. We are sending out a monthly suicide report, and there will be a link if you're not getting that, includes this data. Traditionally, this data set was used to track disease outbreaks, and now we can look at suicide-related visits to identify spikes and to paint a broader picture of what suicide looks like in our state. This chart is displaying suicide-related visits in 2019 through 2021 for youth ages 18 and under. In 2020, we saw lower suicide-related visits to emergency departments and urgent care centers than in 2019. There was a decrease in total visits for all health concerns between March and June of 2020, corresponding with the spread of COVID-19. Suicide-related visits to emergency departments and urgent care centers for youth age 18 and under in 2021 are similar to 2019. I do just want to note that we are not making the case that we have proof of less suicide-related thoughts in 2020, but perhaps there were competing concerns. People were scared and concerned that themselves or others were thinking about suicide, but simultaneously scared and concerned of contracting COVID. So again, the takeaway is that we did not see a spike in suicide-related visits in COVID year 2020 or in 2021 compared to 2019. This is looking at the same data for age 18 to 24. We've really heard from the Alliance and other partners that we need to be showing the difference between under 18 and 18 to 24 to inform the work that the Alliance and all of you are doing in your communities. So the number of suicide-related visits to emergency departments and urgent care centers for youth age 18 to 24 in 2021 is similar to 2019 and 2020. I do just want to note before I move into death data that for hospitalizations, we see an inverse to suicide deaths when we look at male and female. Females are more likely to present to the emergency department or hospital for a suicide attempt or suicide-related event. Females comprised 70% of hospitalization admissions due to a suicide attempt or self-harm. So now we'll be looking at our National Violent Death Reporting System death data, referred to as Oregon Violent Death Reporting System in Oregon. And before focusing on use data, I just wanted to provide some data on over lifespan trends in Oregon. Oregon is one of 7 states that had a statistically significant decreased suicide rate in 2020 compared to 2019. 2021 preliminary data shows suicide increased in Oregon compared to 2020. We continue to see our rate of suicide in Oregon be higher than the US rate. In 2020, the rate of suicide across all ages in Oregon was 18.3 per 100,000, with 833 deaths. The US rate was 13.5. In 2020, Oregon had the nation's 13th highest rate among all states, down from having the 9th highest suicide rate. So having number 1 is the highest suicide rate in the country. In 2018, Oregon had the 17th highest rate in suicide. So while we made improvements in 2020 when comparing across states, we are still the 13th highest and higher than the national average. So let's take a look at some of the finalized 2020 youth suicide data. In 2020, the rate of suicide for youth ages 10 to 24 decreased for the second time in a row. In 2020, suicide deaths decreased nearly 14% among youth 24 and younger. In both 2019 and 2018, Oregon ranked 11th highest in the nation for youth suicide deaths. In 2020, Oregon ranked as 18th. So we have gone down, which is better. Again, number 1 is the highest rate. Compared to 2019, the 2020 rate, suicide continues to be the second leading cause of death among youth age 25 and younger in Oregon in 2020. I do want to note on this slide, Oregon tracks suicides for ages 9 and under. However, some states do not track this or define these deaths as suicide, and therefore to be comparable at the national level and for state ranking purposes, we in Oregon separate deaths for age 9 and under. Moreover, the national CDC defines youth suicide as ages 10 to 24. So you'll note on this slide, we have noted where youth 9 and under have died in suicide, although they are not included in the chart for that national comparison. So again, trying to really respond to the alliances and partners' needs, we're going to look at youth suicide trends for 10 to 17, and then we'll be looking at 18 to 24. As you can see, for 10 to 17-year-olds, we hovered around the national rate until 2011 and then saw a spike. In 2019, the rate dropped below the national rate for the first time since 2010. We saw an increase between 2019 and 2020 with an increase of nearly 25% among youth 17 and younger. While any suicide death is too many, keep in mind that from a data analysis standpoint, we are dealing with small numbers that can cause significant percent changes, even with small changes in numbers. We continue to be trend higher than the national average. Here we are looking at the same comparison for 18 to 24. We've seen an increase in 18 to 24 age group since 2012. Unlike the 10 to 17 age group, we did not see a decline in 2019. However, we did see a decrease in 2020, unlike 10 to 17-year-olds. Preliminary data in Oregon indicate deaths are similar to previous years for youth 18 to 24 in 2021. Shifting back to looking at lifespan for just a moment, this is a chart showing age-specific rate of suicide by sex, male and female, which I'll address in a few minutes, in Oregon between 2016 and 2020. Suicide generally increases across the lifespan, and you can see in gray, that's for all suicide deaths. For men, seen here in blue, suicide rates generally increase with age. For women, in orange, you can see an increase through the middle years and then see decreased rates. Shifting back to looking at the specific Oregon youth 2020 deaths, age 24 and younger, we can see that age 20 to 24 make up 56% of the total suicides deaths. There are significantly more males dying than females, which is also the case across the lifespan. I've provided here race and ethnicity breakdowns for completeness, but it's hard to draw conclusions for counts under 20, and we're going to talk some more about that. So before I share another slide looking at race and ethnicity, just really want to acknowledge that as I spoke about before, the convergence of identity, politics, and inequality provide a unique opportunity to further explore the complexities of race and ethnicity and to improve the way we collect and use data as a tool for social justice. We recognize and acknowledge that the Oregon Violent Death Reporting System does not capture the complexity, culture, richness, and diversity of Oregonians. Data on race and ethnicity are used to identify health disparities and measure progress toward achieving equity. Historically, the focus has been on having people categorize themselves, in this case, relying on family and friends to categorize or to look at data. People who are multicultural or multiracial are expected to choose or have their family and friends, in this case, choose for the person who died by suicide. And only one of the best represents who they are, one that may or may not resonate with them or accurately reflect how they feel. So when we look at, so in blue here, you will see suicide rates among youth aged 10 to 17 by race and ethnicity. And you will see in the orange, ages 18 to 24 by race and ethnicity. I've put them on the slide so you can see them together, but please note comparing between age group 10 to 17 and 18 to 24 is not an accurate way to look at the data from a statistical standpoint. You can see higher rates for non-Hispanic American Indian and Alaska Native, non-Hispanic white. Again, want to note that there are reasons for non-Hispanic American Indian and Alaska Native that we are seeing this, right? There's historical disenfranchisement through genocide, institutional racism that has resulted in American Indian and Alaska Native peoples experiencing poorer health and social economic outcomes. And these really need to be taken in context of what we're seeing with this data. For men, while we're talking about systems of oppression that leads to masculinity and toxic masculinity, which can make stigma for asking for help harder, can lead to isolation, and can increase other risk factors for men. I wanted to talk a little bit about by sex, and you can see here we have male and female. Gender identity is how a person self-identifies as a particular gender, regardless of biological sex characteristics. What we call sex in the Oregon Violent Death Reporting System refers to the individual's gender identity at the time of their death, and it includes transgender identities, so people whose gender identity does not correspond to that assigned to them at birth. There is a separate variable to collect this information. The data point has been in the system since 2013. Transgender suicide deaths are not separated out in this visualization due to small numbers. This is a limitation, and also Oregon Violent Death Reporting System does not allow for identification of people who identify as non-binary or other identity. There is likely an undercount on gender identity data in this data system due to data collection issues, as well as relying on family and friends to provide an individual's gender identity. Between 2015 and 2019, 10 suicides were identified among transgender youth. While we don't have Oregon data, we know that national evidence tells us that transgender women, men, girls, and boys, and non-binary people are more likely than cisgender people to attempt or die by suicide. This is not due to how they identify, rather due to issues of transphobia, acceptance from their families, trauma of experiencing rejection, and not having access to healthcare that supports their ability to live their authentic lives, including through gender-affirming healthcare. We can look at the Student Health Survey for data insight into gender identity among youth. Data has shown that students that describe themselves as transgender or gender nonconforming report higher levels of having seriously considered suicide or attempted suicide. I also want to provide a note on sexual orientation. A person's sexual orientation is the gender or genders to which a person is emotionally, romantically, or sexually attracted. There is a lack of standardized questions and investigations on death in Oregon and nationally creating a challenge for collecting LGBTQIA2+ status among people who died by suicide. Relying on family and close contacts for this data can be challenging if the individual's sexual orientation was not accepted or known to those individuals, especially in the case of youth. Sexual orientation is very likely underreported through this data system. Between 2015 and 2019, 5 youth were identified as gay, lesbian, bisexual, or unspecified sexual minority, which are the categories available through the Oregon Violent Death Reporting System. We can look at the student health survey data, and again, data has shown students that identify as not straight, which include a wide range of categories, but include lesbian, gay, bisexual, or something else, such as asexual, queer, fluid, or pansexual, or don't know or not sure, reported higher levels of having seriously considered suicide or attempted suicide. Again, this is not due to them having that identity, but rather to issues including homophobia, biphobia, discrimination, acceptance from their family, trauma of experiencing rejection among family, institutions, society, and not having access to healthcare that supports their ability to live their authentic lives. I am including some mechanism data here because it's another data point that we need to look at. Again, this is not something that we generally would share in the public, but we need to know this data and examine this data to make informed decision about the work that we're doing at the state and local level. So you can see here on the left, we're looking at 10 to 17-year-olds by age, and on the right, 18 to 24-year-olds. For 10 to 17-year-olds, we see a higher percentage of youth dying by suffocation or hanging, while in 18 to 24-year-olds, we see the leading the leading mechanism of suicide for firearm. The other category here, while a small percentage would include drowning, sharps, blunt instruments, and there are very few, but a couple that are unknown or that data has not been not available through the system, that maybe one a year. So what do we know about 2021? I've talked a little bit about this. Preliminary data in Oregon indicates a decreasing trend in youth suicide for youth aged 17 and younger. And the trend is similar to previous years for youth 18 to 24 in 2021. There is a decreasing trend in youth suicide 24 and younger in Oregon. While the number of statewide suicides for youth 17 and under decreased and are similar to previous years for youth aged 18 to 24 in 2021, the number of youth suicides in some counties did not decrease, and we continue to be higher than the national average. Preliminary data indicate an increase in the number of suicides in 2021 compared to 2020 across the lifespan. As a reminder, we were one of 7 states to see a statistical decrease between 2019 and 2020 across the lifespan. While the continued decrease or similarity in Oregon's youth suicide number in 2021 is positive news, it must be considered in the context that Oregon started this 3-year trend with a youth suicide rate higher than the national average. Far too many Oregon families and community experienced the devastating loss of a loved one to suicide in 2021. And so we must continue doing this important work, both us at OHA, as well as everyone on this call, which is, of course, already happening. I'm getting near the end because I know I'm getting past time. Just wanted to share a little bit about the data sources I talked about today. I really encourage everyone to go look at the data glossary that we've put together at OHA to talk about some of these different data sets. It can be confusing. It can be confusing for me, especially when we have different data sets that look at similar things. So this helps identify what those different data sets are, how they're different. I also want everyone to know that we are working on some significant data dashboard work this year, and we'll be including Alliance members in kind of providing feedback on what that's looking like is what is needed. The OHA suicide prevention team has already been part of this conversation. Specifically for data, you can look at the OHA violent death data dashboards, which has historical data. This is where you can get data available by county. The OHA vital statistics death data, which is not overseen by Injury and Violence Prevention Program, but has is another source to look at, has more recent suicide data. There's county data by manner and method, and there are also historical reports available outside the dashboard. And then again, the National Violent Death Reporting System is, I think every state at this point reports into. In Oregon, we refer to that as the Oregon Violent Death Reporting System, but much of this data is available at CDC. Whiskers, the web-based injury statistic query and reporting system, has national and state level data and lots of videos on how you can use that data source. Again, this will be sent out, but these are just some links. Again, the student health survey is not something I talked about today, but the 2020 student health survey data is out, and there's a brand new student health survey dashboard where you can look at data by a variety of questions, demographics, county level data, and some other links here that may be of interest. So I really just want to end with, this is a lot. Even if we're seeing good trends, you know, we're still above the national average. You know, I think coming to these meetings, this is not my favorite presentation to give at these meetings. I'll just say that because I think this meeting is so much about what can we do. But as Gally said, we need to understand where we are to inform what we are going to do. And that this quote about hope really sits with me, especially when we're talking about data. And so what is your hope and what is life affirming for you? This is a picture I recently took of my wife and my dog, and don't miss my dog Rasso's ball, because that is life affirming for her. So, but this picture is just really life affirming for what brings me to this work, what brings me hope, and how much I cherish you know, working with each of you to continue to decrease and support people that are struggling with suicide in our state.
Megan, thank you for that amazing presentation. That really, I appreciated the way that you explained so many things, and that was evident in the chat as well. So we are running behind on our agenda, and having some conversation about this and questions is also really important, and we want to do that as well. So what questions or thoughts do you have for Megan? Lots of great stuff showing up in the chat.
And I will look through that because I was not paying attention, but for any questions that may be in there. I also want to say we are always looking for feedback on how we are presenting data. Again, you know, this wasn't everything that will be in the YSIPP annual report in terms of data. That would take the whole meeting probably to do effectively. But please be in touch on what you need, what you're looking for, what you're hoping for. And if anything today I presented was like, that's not how I would think about that, or something to consider, I really do welcome that feedback. I can put the link to the article from CDC that had that showed the statistical significance for the other states and the list of those. So I will follow up and do that.
If it's helpful too, I can also pull out the questions specifically for you and then send them to you directly, Megan. So that's an option on the table if that's helpful.
Yeah, I appreciate that.
So folks, there is a question that Megan just, so that do we know the other 6 states that saw a decrease in 2020? So Megan's gonna put a link in the chat that shows where that information come from and what those states are.
No, I just had a comment. This is, you know, I'm here in my role, but I just want to say this personal as a human. As I'm watching what is happening across the country for gay and transgender, lesbian, queer folks, I am feeling so grateful to be in Oregon and also really aware of the challenges. And just, Megan, I appreciate the way you framed the information around transgender families and youth. And it really matters. And this work that we're doing together is really important. And it's not happening all over the country. I mean, it's like really just feel the sense of, we need to show people, like, if we can embrace and just love each other and really support each other thoughtfully, that we're going to have better outcomes. It's going to be a better world. And anyhow, so it's tricky to thread that needle when presenting data, and you did that, Megan, and for me at least, so thank you.
Thank you. I am still learning and growing, as you know, we all are, and but I appreciate that feedback.
So another question in the chat is, are there any school-based strategies statewide to prevent suicide in K-12 schools? If so, where can we find them? If not, where do we bring these ideas? I'm new to the meeting, so thanks. Well, welcome, Amy. We're super glad that you're here. And Megan, what do you think?
Yeah, I think Jill may talk about, I don't want to steal Jill's thunder. Amy, we can put in, so there is a statewide requirement for K-12 schools to have, Addie's Act, to have suicide prevention, intervention, and postvention plans. Jill and Shanda through Big River program have really tried to support counties and schools in doing this work. I think, again, there is a lot of work going on, and I would point you to the Youth Suicide Intervention and Prevention Plan, as well as the annual reports, and the school committee through the Alliance, which has done a lot of work as well. I don't know if Jill wants to add anything else at this point. Okay.
So maybe what we'll do, since that's a nice transition, Megan, if you don't mind, Megan, throw your email in the chat just so people have it handy, even though it'll be on your slide deck, but just so people have it. And then again, Megan, thank you so much for that amazing presentation that packed in a lot in a small amount of time. So folks, if you have questions for Megan or feedback, it sounds like she's welcoming both of those, so please reach out to her or any of our OHA colleagues. We're all in this together, and the more we can put our heads together to do this work more efficiently, the better. All right, before we transition to Jill to share the annual YSIPP report, I want to pause. We have some special guests in the room. Roxanne, do you want to introduce? We have two folks here. I understand they're only going to be here till 11, so I want to make sure that we hold some space for them in the room just to do some introductions. Roxanne, can you introduce who's here with you?
Hi, thank you. I have Alyssa and Braden here with me. They are in our alternative school, and Alyssa is 17 and Braden is 15. They have lived experience, and they agreed to attend the meeting to see what it's all about and to consider joining to elevate the youth voice. And I appreciate that they're welcome to be here.
Absolutely. We love that they're here. Folks, you are welcome to be here anytime. We hope that you come back. Voices like yours as young adults are absolutely needed in this work. And so no pressure. We would love to have you and hope you come back. So thanks for making time in your schedule to be here today. All right, on that note, you all probably know Jill well. Some of you may not know Jill Baker, but many of us do. Jill Baker is the Oregon Health Authority Youth Suicide Prevention Coordinator and actively involved in this work with us very much. And she is going to talk about the annual report for the Youth Suicide Intervention and Prevention Plan, also known as the YSIPP. Take it away, Jill.
Okay, I'm using headphones for the first time, I think, in forever. People can hear me, it seems?
Absolutely, you're great.
Great. I do feel very cool and like maybe a radio personality. So I'll work on, I'll try to keep my head at the right size here. Thank you, Megan, so much for that very perfect presentation. I appreciate you. And the thoughtfulness you bring and the thoroughness you bring, and isn't it lovely that we all have each other to do this work. So we thought it was important to, in the order, to start with kind of the data, where we're at, showing the picture of the work that we've done, and then switch to kind of highlighting and going through some of the pieces of what that work is. Why is it that in Oregon we're have a trend line in the right direction, knowing that there's more work to be done, and what are the pieces and spaces of that. And so this is a preview of what is coming to your inboxes maybe at the end of next week. March 18th is the revised publication deadline for this report. So if you're like, wait a minute, I haven't seen any of this, that's because it has not yet been published. This group of folks is the group of folks that we think about that this team of people is represented in this work. And so we want to make sure that you all got a chance to preview it. So, Gally, I'm relying on you to tell me if I need to truncate my time.
I mean, that would be great if we can not linger too much, but this is important information. So this is the problem we always have in these meetings. We have so many good things, but we also have lived experience to talk about and 988 to talk about later. So, do what you need to do. We'll figure it out.
What is getting back on track? What time would that be in theory? 35.
Yeah, Joe. Yeah.
We'll figure it out.
Okay, if we're done here by 10:50, I think.
I'm on it. This is, I wanted to level set about part of the work that was done in 2021 was around developing our framework for suicide prevention across the state, that it might have felt a bit slow. And here is kind of the map of all of the things that we got done and added in. I want to highlight one of the pieces that feels really, really important, and that we are standing on a foundation that was really well laid at the end of 2020 and the beginning of 2021 around looking at as a state that is chock full of suicide prevention experts and advocates, including all of us in this room, laying our work beside the National Strategy for Suicide Prevention, laying our work beside the CDC's technical package for suicide prevention, a San Diego example from San Diego County, from San Diego, California, and then stirring it all up in the Oregon frame, and what came from that was the framework for suicide prevention, which is where all of the work that we are going to talk about lives. This is, don't try to read any of these words. This is a visual in which I want to make sure that you see the kind of entirety. What's important about all of the work that we've done in the state of Oregon is that we have grown into and have kind of doubled down on the Oregon suicide prevention framework. So when you see the adult suicide prevention plan, it will also look like this, that the work, the tasks that need to be done are different between youth and adult work, but that it all has a place in an organized framework. And part of the strategy here is that we're practicing talking about this framework, and wondering how it lands and what makes sense and what doesn't make sense. And so if you could do us all a favor and listen for how does this make sense to me in my county, in my local coalition, in my school district, as a parent, as a student, where do I see myself in this framework as we go through this? And then having some really honest feedback come to either Shanda or I, and Shanda can put our email addresses in the chat as well. So this framework is standing on the foundation of knowing that we cannot do this work, we can't make progress in the data that Megan shared without really good policy that makes sense and is responsive to Oregonians, without adequate and sustainable funding to get this work done, that is driven by data, knowing that the limits that Megan outlined in the data are real and that we need to get better at that as well, and that we're continually evaluating what we're doing to ask ourselves, is this the right direction? Are we doing the next right step? all of the work is also only valuable if it is centered in the words that come up in the middle. So that how we're going to figure out how to do this work is asking questions about equity. Megan gave a really good example of what some of those questions might be in regards to data. And the rest of us need to also be thinking about what are the questions that we need to ask ourselves in the work that we're doing to center equity, to doing our work in a trauma-informed way, to being able to hear and value and center and elevate the voice of lived experience, to understand that we cannot do this together, but that our impact collectively is stronger, and that we need each other, and collaboration is the way that will make the most progress the fastest. You'll notice 3 sections of this wheel: green, yellow, and orange. The green section is universal. You might also hear buzzwords like primary prevention, tier 1 if you're in a school setting, upstream. These strategies, goals, and pillar in this area should show up for all Oregonians, that this is a universal, everybody should be able to see themselves in the work in the green section. The yellow section is selected. You might hear this being historically called prevention or primary intervention. You might also hear a buzzword tier 2. This is where a lot of the Big River suicide prevention programming lives. This is where a lot of the safe storage and access to lethal means work lives. And this is where we're making strategic choices about protecting protective programming for specific populations that our data and our communities are telling us that we need to do better in. And then the orange section is indicated. This is, you might think of this as tier 3, treatment services. Risk has already been identified, and we know that we need to do something to help facilitate healing. And so the work that's here is around healthcare, capacity coordination, treatment and management of suicidality and suicide thoughts. And then you'll also see the work of post-tension living here. I hope it's okay to Klamath and Clackamas, but I'm using 2 of you as examples of the hope that our hearts hope that when you look at the framework and see, okay, what are the buckets of work? What are the goals that we're working towards in order to make meaningful progress in the prevention of suicide, that you can find your work within the framework. Here's an example. You Matter to Klamath is a local coalition in Klamath. They recently did an amazing video campaign, asked students to create videos about what gives them hope, help, and strength. The PowerPoint that you'll get after this meeting, this is a live link to their YouTube channel where you can see the winning videos. That lives in the framework. That is a green strategy. It's a tier 1 strategy under media and communications. And the pathway name is that all Oregonians receive safe messaging about suicide. So you won't see anything about this particular thing in the annual YSIPP report, because we haven't found a really good idea of telling the story of the collective impact. But this is an example that the 103 initiatives that are named as statewide initiatives in the annual report that you'll read next week is one piece of a very large puzzle of a lot of really good things that are happening in Oregon. State level work only matters if communities are doing good work, which you are. This is a picture from Clackamas County. One of the ways that this work intersects, and that you might be able to see yourself in the framework, is in the yellow section, the goal of means reduction and the pathway that is a statewide supported initiative where we pilot project it to give a pilot project for safe storage for no cost to local mental health authorities. This is an example of that statewide initiative showing up in this Clackamas County humans pickup bed truck on his way to distribute those materials to veterans. And so that's an example of the weaving that we're looking for. As an added bonus, This Alliance to Prevent Suicide just wrote and submitted a letter to OHA asking for mobile crisis response teams, which you'll hear about later in the meeting, as a recommendation to include safe storage items when they're responding to a crisis. So that is an example of how all of the pieces might fit together. Here's what you can look for in the annual report that will be coming out next week. Each of the sections, the green section, the yellow and the orange section, and the buckets of work are further kind of teased out in initiatives or tasks that the Oregon Suicide Prevention Team and our contractors and our partners have agreed to do, including 15 initiatives that the Alliance to Prevent Suicide agreed to do. So the annual report is a chance to say temperature check and say, where are we at with all of these things? If I had spent more time on that first slide of the timeline, you'll notice that the YSIPP 21-25 was published in December of 2021, and we are now just in March of 2022. And so you'll notice that many of these are things that are work that was already done, and you'll notice, and so they might be under a category of achieved. Other things we're just getting started on, and so you might see that the status update is something called early action. Here's the key for what those things will mean. And so we kind of categorized them in where are we at with this initiative for all 103 of them, and then color coded them to say, right, so we're just getting started, but that's what we had planned, so we're on track. Or this is in progress, but we have a significant barrier, and so now it's in a yellow or a red status update because we're missing deadlines now because of that, that piece. I am not watching the chat, and so if there's anything I need to be interrupted about, I'm trusting somebody will do so. So you'll notice, actually, I'm going to go back. So you'll notice on the annual report that each of the specific initiatives for the YSIPP have both words and color codes to see where they're at, and then a narrative section describing it. So for example, this one, under coordinated activities, the strategic initiative is to organize the people, staff, and infrastructure of suicide prevention across the state. We are still early on that process. We've missed some deadlines, and so it's yellow. So it's not green, all good, but it's also not red, we're missing everything. And then an explanation of what has happened in that initiative versus Big River statewide coordinators meet monthly to align. That's something that happens regularly. It's going really well. So it is both achieved, which means it's sustainable and done, and green, that we don't have any concerns about where it's at. One question that we want to make sure that we are getting really good at answering is, where can I find who is leading a specific initiative? So there's a link here in the materials to an active tracker that will show you, again, by color-coded section of where in the framework an initiative lives, who is leading that work. These all happen to be Oregon Health Authority, but as I said, 15 are Alliance to Prevent Suicide. Who is the human that you can contact to ask about that work, and then the status update that matches from the annual report. I want to give some highlights. This might start to answer Amy's question about what's happening. Here's a snapshot of some of the highlights that you'll read in the annual report, and I'm sure you'll memorize the annual report. That we know our Big River Suicide Prevention Programming, which again, some are in the green section, most are in the yellow, and then the advanced skills are in the orange section of the suicide prevention framework. That right now, 33 of Oregon's 36 counties have an active trainer in one or more of those Big River programs. And the 3 counties that don't have a resident address for a trainer are covered by neighboring counties in Oregon. We know that 1,257 trainers exist across the 8 Big River programs that we have train the trainer structures for, and that in 2021, in a year of a pandemic where everybody is doing the best they can with what they have, Oregon, we added 391 new trainers to that total in 2021. That is not insignificant. Mental health providers in the state of Oregon took us up on our offer for free suicide prevention treatment or advanced skills trainings. So these are for clinicians or mental health providers. 544 providers received training across one of the 5 course options that OHA sponsored in 2021. Here are some examples of highlights, but also where we got to get better. So for example, in our Big River programming, we've asked our statewide coordinators to look and assess for cultural responsiveness and community adaptations that might make sense. And so of our 8 Big River programs, 7 of the 8 of them have actively worked in 2021 to move closer to something that's culturally agile, cultural adaptations, or culturally responsive. 2 of those programmings are right now available in Spanish, and 2 more will launch Spanish options in 2021. And this is absolutely an area of work that we have to get better at. Each of Oregon's 9 federally recognized tribes and NARA Northwest receive some funding and support for suicide prevention directed by the tribes. This means that the tribes themselves tell us what their suicide prevention efforts will be connected to that funding. So some of those are what we might have built in or thought traditionally of suicide prevention around policies or screening or safety planning, that type of thing. And many of it is in the green upstream primary prevention category around connection to culture, cultural camps, and positive youth development strategies. In summary, one thing that we did was that we published the YSIPP 21-25. We leaned into the theme of growing roots, that we have a lot of really good things happening, and we need to make sure that there's a rootedness to be able to create strength in communities. We have worked towards deepening the connection and helping us all kind of see where we live in the Oregon Suicide Prevention Framework. We've done a lot of work on making sure that we are organized, that we know our roles and our responsibilities. The foundation has been laid for the adult plan. And just as a note, the difference between what we are doing this year, what we're focusing on this year, and what we might focus on next year, we will go through a mini process of that first slide. We'll go through a mini process of that to ask ourselves, what are we doing? What's working? What do we need to grow? What do we need to prune? And have the youth suicide prevention plan be a living, breathing document where we can respond to what it is that we actually need to get done. That's it.
Wow, Jill, thank you for being so efficient and speedy and giving us so much amazing information. What questions or thoughts or feedback do folks have for Jill? Okay.
You know, Gally, one comment I would have is just that I think we'll take this presentation back to our various committees and also the report that comes out so that we can take a little more time to reflect on it and see where we've grown and where we're moving, and think about if there's any feedback to give. But we've come a long way, baby, in the last 5 years. That's for sure. Yeah, we are, as an alliance, we are trying to get better at any report that OHA issues. We are trying to be very intentional about issuing a response, whether that's you all are rocking it, like let's keep doing it, or like, hey, what about this? Can we work on this a little bit better? So this will allow us to continue to kind of grow and stretch a little bit as we learn how to do this. And so we'll take like Annette said, we'll take a closer look. And again, when it comes to you, I would encourage you to take a closer look. And as members and affiliates of the Alliance, if you have information that you would like us to include in that letter to OHA, because it will be coming, please let Annette or Jen or me know.
Lots of good stuff in the chat, Jill, for you. Lots of appreciation. Okay, folks, we are scheduled to take a break for 10 minutes, and I'm gonna steal your thunder and ask that it just be a 5-minute break, just so we can have time for lived experience and 988 and other things. So if you could please be back, let's go till a 6-minute break, 11 o'clock. Get some coffee, take a bio break. See you at 11. Why? Which is, oh, that creepy voice for the recording always throws me off every time. 988 is coming very, very soon, and the mobile response is coming. So we have folks from OHA, from AOCMHP, and from Lines for Life here to talk about all the things. So I don't know who's starting, but I will hand the floor over to our guests. Thank you so much for being here today to talk about this.
Probably it would help for me to unmute. Hi, everybody. I'm Beth Holloman from OHA, and I am happy to be here today to talk a little bit about 988 and the rollout in our mobile services. We have Rusha is going to actually kick us off for this portion. So I have a slide deck I was going to go over, but we do have a whole panel of folks who are going to be tag teaming this presentation today. So maybe we should all introduce ourselves first. So Rusha, do you want to introduce yourself first?
Sure. Hi, everyone. My name is Rusha Grinstead, and like Beth mentioned, I'm one of the folks here from OHA to present to all of you. Thanks for having me here. I am in behavioral health policy at OHA, and my job is to oversee the design and implementation of the 988 and the behavioral health crisis system in coordination with the child and family behavioral health system, which is Chelsea Holcomb's team, and also to establish our the 988 program here in Oregon, along with all the other states. Thank you for having me.
I can't see everyone. Well, Cheryl, I can see you. Do you want to introduce yourself?
Hi, everybody. It's good to see you again after so long. It's been a really long time. I'm really happy to be here again. I'm Cheryl Ramirez. I'm the Executive Director of the Association of Oregon Community Mental Health Programs, and I'm here to talk about the CMHP role in the crisis system.
And then I think I saw Chelsea.
Hi, everyone. Chelsea Holcomb. I use she, her pronouns, and I oversee the Child and Family Behavioral Health Unit that supports the work that you all are doing and this exciting initiative. So happy to be here.
And Dave Westbrook.
Absolutely. David Westbrook, Chief Operating Officer at Lines for Life, use he, him pronouns. Really excited to be back in this room with folks. And I'll talk about the crisis lines piece.
Wonderful. Well, just a little disclaimer, we as a group have not presented together. We didn't get a chance to practice. And so we are going to do our best to pull together all of these great things that are going on and give you guys a full overview of the 988 and the crisis response system. And there's a lot of hard work that's going on in multiple different areas of the implementation. Rusha just turned off her camera, but I am in the process of pulling up the slide deck, which she's going to actually kick us off today. So Rusha, I hope you're not far. Let me pull up, let me pull up the slide deck.
I was just sitting down, standing.
All right. Can somebody give me a thumbs up if you can see the slide deck?
We can see it, Beth.
Okay, let me put it into the right mode. And then Rusha, why don't you get us started, seeing you are the project lead for this whole project. Give us a little overview of the crisis system and what's going on.
Sure. And okay, there we go. So hi, everyone. Like I mentioned, and like Beth mentioned too, there is a lot of work going on in enhancing and improving Oregon's behavioral health crisis system. And it is, and it has several components to it, which is kind of trying to align as much as possible and how it works out for Oregonians, the Crisis Now model, which is the best practices in behavioral health, and has been endorsed by our national partners like CMSA, CMS, NASHBIT, and all of them. A little bit of context for 988, and I'm sure David will cover some of this too, is that right now there is a national suicide hotline phone number, which is the 10-digit phone number that we are all familiar with. And back in 2020, October of 2020, a federal law was passed which established a 3-digit number 988, and in July, starting July 16th of this year, that is 2022, the National Suicide Hotline will be replaced by this 3-digit phone number. And this is the result of years of advocacy in Congress from all of our national partners, especially SAMHSA and NASHBIT. And the reasons for doing this was it is obviously a much easier number to remember than a 10-digit phone number. And then also to really establish more behavioral health response to behavioral health crisis. And just like how we have with 911, which is where you are able to get law enforcement or fire or EMS, this kind of responses for behavioral health, just those kind of responses to a behavioral health crisis is not always appropriate, as we all know. So that was another reason for all of this advocacy. And then also overall to reduce stigma around mental health crisis, and really establishing an easy way for individuals to reach out to the behavioral health system when they're experiencing a crisis. So all of this led to the National Suicide Hotline becoming 988, and there is a lot of coordination between SAMHSA and the Veterans Affairs to make sure that there is coordination between the two. And then you'll see here that I've listed some of the priority populations, which are very similar to SAMHSA's priority populations, so veterans and their families, LGBTQ youth, communities of color who are historically marginalized, rural individuals, and then other high-risk populations, individuals and families with higher needs. And the other thing that the 988 federal law had also authorized states to do is states, if they want to, can establish a fee on telecom providers. And there are some states who have done that through legislation in 2021. Oregon is not one of those states, but that is something the federal law authorizes states to do. So then the other context behind this 988 is also years of support and advocacy for this Crisis Now model. And what the Crisis Now model really looks at is 3 components that should comprise a crisis response. So one is a place to call, somebody to respond, and a place to go. So 988 is really that first component, is a place to call when you are experiencing a crisis. And then somebody to response is where mobile crisis and mobile response and stabilization services, which is the more appropriate response for children and families. And that's that component of somebody to respond. And then the last piece is crisis stabilization services, establishing a network of crisis receiving center and stabilization centers. And that is the component of a place to go. So for Oregon, Beth, if you are controlling this, guys, oh, thank you. I was going to ask you if you could go to the next one. So thank you. So like you see here, the whole concept is just how we, with 911, there is this chain of events that happens to provide response to an individual who's in crisis. That's what that was the effort with establishing 988, that when you call 988, you're getting a behavioral health response. For those who cannot be de-escalated over the phone, there is a response through mobile crisis and mobile response and stabilization services. And then you are receiving stabilization services following mobile crisis response, and then following that you're being connected to behavioral health services either in your community, or if you need a higher level of care, making sure that the individual and the family are being connected to those services. So it's those parallel lines. This particular picture here, there's a lot of pictures and arrows and words in here, but what this is really trying to show is, as you continue to hear about 988 and the mobile crisis and mobile response system, and then stabilization services, this whole system, as you continue to hear about it, we keep updating you and our communities as we keep building the system. This really shows the system at its entire complexity, and how this behavioral health crisis response system sits within the state in conjunction with other crisis services. So which is where that 911 and 988, those two streams of pathway that's shown here. And then also there needs to be a coordination between 911 and 988, which is also a new partnership and effort in collaborating with our other crisis services partners, which is 911 programs that we have started. So as you can see, there are some calls, there are some individuals and families who, when they experience crisis, that may be at a level of risk where there needs to be a law enforcement response when the call goes to 911. But then also what we're trying to make sure that whenever there is a behavioral health component, there is a connection between 911 and 988. And then in the middle there, the boxes which have two colors in them, those are the ones where there might be the necessity of a co-response between EMS and mobile crisis, or law enforcement or mobile crisis. And then there are individuals and families who just need mobile crisis response because there are no other immediate risks of harm to themselves or those around them is presented. And then the last row of boxes shows what are all the various services within the community, and then all the services which are at a higher level, including inpatient psychiatric hospitals, or if an individual just needs to go to a crisis receiving center, and then, or if somebody needs to be at an emergency department. So these are all the places where individuals can go. But on the very right-hand side, you'll see there is an arrow that directly goes from 988 to the community agencies and connecting individuals to MRSS response. That's for individuals who are directly reaching out or just walking into a stabilization center in their community, or into a walk-in clinic in their community to access behavioral health services. But overall, the goal is that we have all three levels of a crisis response, somewhere to call, somebody to respond, and a place to go. And that all these three components within this crisis response system are working with each other and are also working with other crisis services partners such as 911. Like I mentioned, when 988 was passed, it also kind of snowballed into a slew of legislations at the federal and state levels across the nation. About 26 states passed some kind of legislation around 988 and building out their crisis system. Because with 988, the anticipation is that more people will reach out. So we want to make sure that we are enhancing all the services that follow a call to 988. So in Oregon, we passed House Bill 2417, which directs the Oregon Health Authority to establish the behavioral health crisis system aligned with best practices. And establishing those three components of that crisis system, the 988 call centers, the mobile crisis and mobile response and stabilization services, and then crisis stabilization centers and or crisis receiving centers. Thank you, Beth. So House Bill 2417 appropriated some funds to Oregon Health Authority. Since 2018, we have had some dedicated funds that have been going to our CMHPs for mobile crisis services. And Cheryl will talk more about that. But what happened through 2417 is that additional $10 million was added to mobile crisis and mobile response services that would go directly to our CMHPs every biennium. And then the other piece was $5 million to go towards our 988 call centers. And in Oregon, so far we have 2 988 call centers because only those organizations who are already accredited by the National Suicide Hotline are the ones who by default become 988 call centers because they have the existing infrastructure and the operating and clinical standards that come with it. And then since House Bill 2417 passed, we also started aligning ourselves with other federal efforts, and one of those being a higher Medicaid match for mobile crisis, community-based mobile crisis services. And that's the work we have started doing a lot with our CMHPs regularly. And so what we did is we essentially worked with our CMHPs to identify how much would be appropriate funding to at least start up and get the workforce and the mobile crisis teams in alignment with the CMS requirements. So we had 10 million from before and another 10 million that's added through House Bill 2417 for mobile crisis, and we added another 11 million in startup funds, which is one-time funding only, that we will be distributing to our CMHPs to help them establish their mobile crisis services and teams in a way where they're able to align with the best practices. And then there is also anticipated funding for mobile response and stabilization services, which Beth and Chelsea will talk about during their presentation. So this picture here, this is really to show that how we have been working with our communities and really following a community guided and community led approach to establish the behavioral health crisis system and build on the existing infrastructure that we currently have. So the CSA, which is the Crisis System Advisory Work Group, and there are some folks here who are part of that work group. It's primarily composed of individuals and families with lived experience and individuals and families who have experienced the behavioral health crisis system and still do when needed. And what the approach we're taking is really understanding from them that how do they want to experience crisis services when they reach out and seek behavioral health crisis services in their community. And taking their recommendation, we are then working with our providers who are our CMHPs that deliver these services and bringing them together to look at what would the community want to experience and what are the challenges and barriers that our CMHPs currently have, and what kind of resource and support do they need from OHA to be able to deliver the quality of service that their communities are asking for. So that's the dotted line on the top there. And we have started that work this month with where CMHPs have been coming regularly to that crisis system advisory work group and having conversations with that lived experiences group and discussing the recommendations and understanding barriers in the community that currently exist and identifying the resource and support that they would need to remove those barriers. So taking those, we are really using that information to drive policy change, to drive establishing minimum standards, minimum requirements, and then turning that into resources and how do we fund those resources, so like workforce, other funding needs in the community for CMHPs, how can we leverage more federal funds such as Medicaid to sustain this enhanced system, and then also establishing accountability across the board. And then the last box there, it really shows that how that's all going to be reflected in our statutes, our administrative rules, contracts, our metrics, and all of those things. So this kind of is the engagement model that we are using with our communities and CMHPs in conjunction. And that's what this picture is showing here. And then I think the next slides are more focused on the MRSS, which Beth and Chelsea will talk about. But I don't know if people wanted me to pause for questions before we dive into that.
Yeah, I actually thought I see that there's some chat going on and I haven't been able to keep up and do the slides. So if there's any questions for Rusha, and then I just wanted to also throw out there, Greg, this might be a good time for you to follow Rusha's discussion scene. She's talked about 988, maybe to talk. I see some of the questions are specifically about the 988 call center. So it might be a natural handoff to Dave next to talk about that. Questions?
It looks like the questions in the chat have been resolved.
They all have been. Great. Any questions for Rusha?
This is Laura Rose. I just had a quick question. I know they had a round of applications for CSAW. Is there a time when the results might be announced?
Yeah, Laura Rose, off the top of my head, I believe the date that we had announced was end of March.
Great, thank you.
All right, well, I will jump in and I will first of all thank Rusha because she did such a thorough job that I don't have a ton to add, but I have a few points to add. One is that in addition to calls, the FCC also approved 988 for text and chat. So it'll be the first time in Oregon, other than our youth line, that we have robust text and chat services on the suicide prevention line. Right now, the National Suicide Prevention Line has chat and text that they do operate, and they are only able to respond to about 30% of that total digital. So that tells you a couple of things. One, that a lot of text and chats are going unanswered there. There's huge demand for it. And it's part of what we expect will drive volume at the Crisis Lines Contact Center. Rusha mentioned that there are two centers, Northwest Human Services and Lines for Life. Northwest Human Services covers Polk and Marion counties, and Lines for Life covers the rest of the counties, but Lines for Life will cover all of the counties for the text and chat volume. This past year, we got about 30,000 calls, a little shy of that, but around 30,000 calls on the National Suicide Prevention Lifeline. The modeling that our national partners have done puts us at 80,000 to 110,000 calls, texts, and chats starting from July 16 forward. So you can see there's a huge volume increase there. The other thing that SAMHSA, the Substance Abuse and Mental Health Services Administration, has determined is that they're going to have a new metric, which has never been applied to National Suicide Prevention Line before, which is that all of the calls have to be answered, 95% of the calls have to be answered within 20 seconds. I can tell you that's a very big leap and a very big difference. And it's going to drive some pretty significant staffing changes at Lines for Life, and I imagine at Northwest Human Services, to be able to catch up with that volume, with that metric. I do want to mention the telecom fee, and I want to make a pitch for it here. I want to point out first and most importantly that that telecom fee can go to two other things besides the crisis line. It can go to mobile and it can go to crisis stabilization services. And while I applaud our legislature for putting in $10 million for mobile crisis, it is a drop in the bucket for what this state needs for mobile crisis. I think Cheryl will, expand on that, but there's no way that that's enough money to respond, even with crisis line centers around the country meeting about what Lines for Life's metric is, which is a de-escalation rate of somewhere between 95 and 98% of the calls. What we want is people who need that mobile response to get it really quickly. We don't want a situation where somebody has multiple jobs to do and also the mobile crisis lines, right? I sat with Chris Boneff from NAMI last night at Lines for Life's dinner, the first one we've done in 2.5 years. And he said to me this, mobile crisis should be like fire departments. There should be one that available in every community, and they should be available 24/7 in that way with that kind of staffing. And I just really appreciated that perspective and agree with it. And then also really important for the crisis center, mobile crisis will be important for 988 to be successful, and then crisis stabilization services will be really important. All of those are going to be run probably by AOCMHP partners, but it doesn't really work. The line doesn't work fabulously, and will have some people thinking that it failed if we're not able to do some things like divert some of the traffic that's behavioral health emergencies that wind up in the emergency room right now away from there. So that initiative's there. The reason the telecom fee, one more thing about the telecom fee, the reason that it makes sense, because not everybody who calls the crisis lines by a huge percentage point is Medicaid, right? And so we're going to ask Medicaid, OHA is working on this, to pay some of that bill. But we know from answering it, there's a lot of these folks aren't Medicaid folks. When the telecom fee for 911 is something like $1.25 per call. The thing about the telecom fee is every time a line or a mobile phone gets added, the fee goes up. So as the state population expands and you have more people having phones in state, you're going to continue to see that fee increase. Right now, the federal government is promising a significant amount of money to go to 988, and I love that. And I just want to say that's administration dependent, right? That can flip on a dime depending on what the priorities of the next administration are. So that is not a good solution. It's a good start, but it is not what Oregon should rely on for funding the 988 and Crisis Now system. I think that's all that I wanted to add, and I'm very open to questions now or after others have gone as well.
Are there questions for Dave about the Lines for Life 988 response?
I saw a question in the chat. Jacob Dilla asked, would we be able to have this group of presenters come provide TA on this as we're setting up our own stabilization centers?
And Alliance for Life would be glad to be part of that and have our training team do whatever training, Jacob, your folks would want.
And same for OHA. I mean, we want to be able to help and have the community up and running and connected as much as possible, because we're going to need to have a really smooth, seamless back and forth between all of these different components.
David, one question I have for you is, it's just hard for me to imagine the level of staffing up that you're talking about when I hear that well, I don't hear, I just know viscerally that there's this giant workforce crisis in our entire country, let alone in the behavioral health workforce. And I guess I'm curious about how are you all approaching that and how can we support that?
Well, the support that you probably gave, blanking on the number, this past legislation term to have funds and retention from the legislature is certainly helpful. Luckily, crisis lines were included in that bill. There's no doubt it's a challenge. I mean, I guess really also I just want to get us all thinking about that as a long-term challenge. It's a challenge now. I have not seen any predictions that it gets better. It actually gets worse. And so things that like the Alliance could do is really encouraging two things, I think. One, people to go into the behavioral health field, and two, encouraging programs, educational programs around the state for the behavioral health field. So we should all be looking at this also as a long-term and something that not the Alliance isn't good at. We just as a society aren't good at saying, oh, climate change is out there, right? We should do something about it now. And we don't want it to get to that wildfire kind of place with behavioral health care.
Any other questions for Dave? Otherwise, I'm going to see if Cheryl, since we have been focusing on 988 and the transition and kind of beefing up the mobile response that already exists across the state, that the CMHPs, I wonder if it would make sense for you to jump in and kind of talk a little bit about the role of the CMHPs.
Sure, be happy to. I know a lot of you know what we do as CMHPs, community mental health programs, but there are also some newer people. So I just wanted to give some very brief background on the CMHP role in the behavioral health system as a whole. So we have community mental health programs across the state. They are county-based. Some of them cover more than one county. We have one tribal CMHP in Jefferson County, Warm Springs. The way that they're structured are either through county departments, and you'll see those counties in green are county departmental CMHPs, and the blue ones are not-for-profit agencies that are delegated, contracted to be CMHPs. I'm sure you'll see a pattern in that it's the medium to larger counties population-wise that have county departmental CMHPs, and the more of the rural frontier counties that have not-for-profit entities that do the CMHP work. But as you can see, every single county has a CMHP. So that's my point. So we are statutorily required to do a number of things across the system. I would say our overarching role is as the local behavioral health system manager, and CMHPs provide a whole lot of direct service too. In the larger counties, they subcontract a lot of services to other providers, and in the smaller counties, especially rural, they could be the main behavioral health provider there. So I have a better version of this slide, which I'll send. I just was trying to stretch it out, and it got a little fuzzy. But this is basically our work plan for the group that Rusha had mentioned, really focused on mobile crisis response. And this is what we're all doing. I'm certainly not going to go through all of this, but it is just to say that we have figured out how to equitably divide the 10 million that Risha was mentioning from House Bill 2417, by population and by a number of public health, social determinants of health, equity factors. It's not a perfect formula, but it will be distributed across the state, and we'll probably tweak that formula for future funding. So this will allow our CMHPs to hire people. That's really the biggest deficit right now in the crisis system is the workforce. And I know everyone said that, and I'll just say it again. It's our biggest challenge. Crisis services are very difficult. It's a difficult part of the behavioral health system. I mean, you see people at their worst. You've got to work, evenings, weekends, and, it's just hard work. And the pay for the public behavioral health system that manages this work, it's not the best. We've got kind of an upside down wage system, but that's a whole other topic. So one of the big buckets of statutorily required services that community mental health programs do is crisis services. So CMHPs are responsible for crisis lines, for mobile crisis response, and crisis stabilization services. So really it runs the whole gamut, even though this particular work group is really focused on the mobile crisis response. I was really glad to hear David say that Chris told him we should have a firehouse model. That's really our philosophy. We should have the same type of capacity-based funding and response that firefighters or EMS in the medical system have. And that is that we pay for people to be there 24/7, as opposed to trying to work it out with billing codes and fee for service. And, we're very grateful that we have this funding from the state and also through ARPA funds, federal funds, as well as the enhanced match from the federal government in the future. But it'd be great if we were just capacity-based funded, and so we just would have the funding for people to be there 24/7. So that's all I'll say about that. So at this point, I think we can probably move to the next slide. So I wanted to just give a brief update on the status of our mobile crisis response. I am not going to read all this. I mainly want to show you that we have in place a mobile crisis response system. It's been 24/7, 365 since 2018, when we got that initial 10 million investment, as Rusha mentioned. We have some things that some CMHPs are able to provide, for example, peer support specialist as part of their mobile crisis team. And then we have the future state for all. And this comes straight from the plan that's been drafted by Rusha and others. And we're going to use all of these expectations in a community mental health program self-assessment so that we can plan for the future, figure out what we need to get there, and that will help us decide how to use the 11 million from the additional federal funds through SAMHSA. So this is where we're at. I just really want to show that we do have some things set up already up in the left column, and we just, we have some work to do, especially in terms of the MRSS component, and just really moving from probably a predominantly paired law enforcement model to a predominantly behavioral health response only model. I also think, just to link to what David said, in terms of the crisis lines, as I mentioned, that is a responsibility of CMHPs too. And just as an example, in 2020, CMHPs had over 174,000 calls on their crisis line. So I think there's some work to be done to coordinate the crisis line calls that we get at the county level with Lines for Life for 988. And there's a whole transition that needs to happen between 911 and 988 too, because people are just used to calling 911. So there's just a lot of work in that space to be done. And in terms of the crisis stabilization part, and here's where I'll put out another pitch for the telecom fee. We're going to need everybody, all of us, really advocating for that fee, because I think that's the only way we'll get to enough crisis receiving centers statewide, and that will help us get to that third phase of crisis services, so that people have somewhere to go to figure things out for up to 24 hours, 23 hours, and it'll help us divert people from perhaps going to jail or a higher level of care that maybe they don't need. Maybe they just need that time to decompress, get basic necessities, maybe medication, sleep, and maybe a housing situation. I mean, there are just a number of things you can do at crisis stabilization or receiving center. So I think that's a big, big priority for a lot of us, and we all need to band together to make that happen in the 2023 session, so that we can really build that part of the crisis service system up. You can go to the next slide. This is just a continuation of the mobile crisis response status, and again, not reading it, but just want to let you know where we're at. So we're not starting from scratch, we're just in process. So I think that's all I've got.
Questions for Cheryl about the role of the CMHPs?
I'll just make a quick comment, Laura Rose. I made a comment in the chat too, but we're also hoping that peer respite will be coming online, and the first phase are 4 that are hopefully going to be opened in the fall. We had wished we could get them sooner, but it takes time with all the rulemaking and everything. However, hopefully there'll be more options in the future. This is just kind of an initial piece, but to accompany that. So if people don't need the higher level of care, they can receive help in a home-like environment.
Thanks for mentioning that, Laura Rose.
So I just wanted to do a quick time check with Annette and Gail maybe, and see, are we?
Beth, you have until 12:30. I'm going to do the last 10 minutes that was scheduled for me. I'm going to send that on to everybody. So right now it is 12:10.
Okay, well then we maybe, Chelsea, should we jump into some overview of the kids system? That's what our role is going to be. Child and family specific is what Chelsea and I are focusing on, is how do we have a customized response once 988 kind of triages the calls. They're hopefully going to resolve a lot of calls that come in, but then there's going to be the stabilization, the mobile response, who responds. So you spent a lot of time thinking and talking and getting information and research about what's the best model to respond to the community, to respond to children, youth, young adults, and families. Chelsea, do you want to say anything before we jump in?
Yeah, just that this is sort of a 40-minute presentation that Beth is now going to fly at you in a few minutes. So I think we also have opportunities for folks who want to dive deeper into community conversations. So if this is of interest, we can either come back, we can create a separate community conversation just for this group, or you can come to community conversations as well. So yeah, I think let's get through what we can get through and see where we land with the group.
Great. Yeah, so I'd be more than happy to come back. And like Chelsea said, I can also send the dates and times of our community conversations, which are open to the entire community, which we do a similar presentation. A lot of the things that I was going to talk about have kind of already been touched by our other presenters. So let me share my screen here and see how much we get through. And Chelsea, you're going to jump in or answer the chat box. However, I'm just gonna forward through some of these slides. All right, so you guys can see my box, right? You can see the slides right now. Thumbs up, somebody? Yeah, I got a head nod. Okay, thank you very much. So again, we are working really hard with the CMHPs and Lines for Life to have a streamlined process from the time somebody in the community picks up the phone and calls 988, that triage piece, and then how 988 will then notify the counties, and the counties will all have that quick response we were talking about. And so 988 is for the lifespan, mobile response is for the lifespan, but we really wanted to make sure that we are thinking specifically about how to customize the response to meet the unique needs of children, youth, young adults, and families. And I keep saying all of those: children, youth, young adults, and families, because ideally we are open to serving 0 through 20. So we cross over to that young adult, and 988 will be working really closely with 988 to help kind of establish when might the children's mobile response trained folks, what, you know, who responds to those that fall into that 18 to 20 year age between the adult system and the children's system. So that's something we're actively thinking about and working on. I bring up this slide here, and Rusha talked about House Bill 24, which is in the middle here, but I also wanted to let you know that there are rules, which we call Oregon Health, or Oregon Health Authority has Oregon administrative rules, that currently right now are in the process of being updated. And part of the reason we're updating it is to meet the best practices that we have researched, and to be able to incorporate the feedback we're getting from the community. So although we have current mobile response in all of our counties already, and they're pretty well developed and they offer 24/7, we will be looking at expanding some of the requirements and making sure that we're meeting specifically the needs of youth and children within this, within our rule set. So a couple things to know is that before, previously, historically, all of the mobile response kind of lived under the adult side of the adult behavioral health system within OHA. And so one of the things we've done is we've really partnered on this project with the adult side to make sure, again, that we don't forget about children, youth, and those young adults and their families, and that we're making sure to include language specific to meet those needs. And so we have kind of are now tag teaming the mobile response and making sure that we have children and families are not left out of some of the language as we're rewriting what we call service elements, which are our contracts with the counties, and then the Oregon administrative rules. So we did a ton of research around what does it look like? What are other states doing? What's going on nationally? What are the best practices? So we did a lot of research nationally, but we also did a lot locally to elicit the voice and experience of youth and families. One of the things that I just highlight is that the University of Maryland does a lot of research and a lot of technical support on the mobile response services. And two of the big things that they had put or alerted the community to was that in order for the child and family system, that we really need to develop more comprehensive, sustainable, and effective community-based services for children, youth, young adults, and their families. And that also it's really important that communities also look at expanding and promoting crisis services that are specially customized for children, youth, young adults, and their families. And so I just put that out there for you guys because the Child and Family Unit at OHA has really done we've worked really hard. This first bullet in this past year, even though it's been a pandemic, we've really tried to start up an intensive in-home behavioral health treatment, which is in-home, a community-based alternative to residential treatment. And then we are also now moving forward with a customized approach to crisis response. So we took those two recommendations very seriously and are trying to align Oregon's practice with the national best practices. You heard Rusha talk about the Crisis Now model that is really the base model for the adult mobile response side, but also that we're all seeking technical assistance from our national sponsors, the Institute of Innovation and Implementation, SAMHSA. There's lots of different places and different committees and conferences going on nationally since 988 came down as a federal mandate. So I just want to take a couple minutes, and I said to talk specifically about children and family and share with you some of the things that we're hoping to incorporate into the mobile response and stabilization services. We're calling the response to children and families, we're calling MRSS. So when I say MRSS, I'm speaking specifically about the children and families that we would be responding to, with a specialized team that's specially trained in working with children, youth, and young adults. So some of the national best practices, we didn't have to start from scratch in Oregon. We had our friends here nationally that are already doing these services. And so we tried to look at and research the best practices from the University of, the Institute of Innovation and Implementation. What did they find are the best practices? And I know that this document is hard to find or hard to read, but a couple things is that we want to keep kids in the community. We want to keep them with their families. So if we go to initial response, instead of having somewhere to go, we want to do as much as we possibly can to help stabilize the family in the community that they live in their own home. So part of what makes this unique for child and family response is that we are, in addition to being able to respond to that initial crisis, we also are asking that the counties can also provide services for up to 56 days. So we don't want families having to call 988 back and forth, and we come out and we go. If their family's situation, we can deal with the initial crisis that prompted the phone call, but we also want to ensure that we are helping to support that family to keep them from re-escalating and help them connect to community resources. So we have this 56 days of follow-up that is also on the table, as far as would be the stabilization services. So that's straight out of the best practices. The other thing too that we really wanted to, and I'll just highlight for you guys, there's a lot of best practices, but the other thing that's super important is, what is the definition of a crisis? And I think a definition for the crisis in the adult side is a little bit different than how we think of crisis in the children and young adult system. We want to be able to have a lower criteria that's realistic. We want families and youth to be able to say, hey, this is a crisis for me. I need someone to come I want someone face to face. I would like to be able to have somebody come out to the home. So we really want to look at what the definition is of crisis and how those decisions are made to have somebody respond in person. And we don't want to make it impossible to get that face-to-face response. So those were two areas that we've just been really looking at and talking to the community about. So that's that first bullet here, that the crisis is defined by the caller. It's available 24/7, which our mobile responses already are. And that we try to help stabilize services if needed past that initial crisis, while we're working with the community and working with the family to identify and hand them to help connect them to their next services. Chelsea, do you want to jump in and just talk a little bit about the mobile, the timeline that you created?
Yeah, sure.
Thank you.
Yeah, sorry, I was like, by Friday, my computer just is tired. So I think, again, I just feel like we're trying to cram a lot of information into a short amount of time. So again, I think it may warrant further conversation. I just want to name that. So I guess what I would say is that our unit and the legislature and the community have been trying to work on this issue for a long time. And the emergency department has been the front door, and we have made youth and families have to prove how much in crisis they are in order to get stabilization services or get mobile response. And as Beth was saying, we're trying to go more upstream and really listen to youth and families and trust youth and families. So this timeline is just to show that, Oregon's been aware of this issue and aware of the need for more resources at the county level and throughout our communities to do this work. And so where we are now, as Beth said, is that we're looking at Oregon administrative rules. We're looking at learning collaboratives. We have new staff who wasn't able to be here today to help coordinate some of this work between 988 and the mobile response. And our hope is to, have the full funding in addition to these other funds that's been talked about that's going to the counties for infrastructure and support for mobile response fully funded by January of 2023. And I don't know where the other slides are, but this includes looking at existing funding that is involved in our crisis and transition services programming, merging with this to create this full model so that it can go statewide and not just within the 11 counties that we have. So, I think as what was said, we know this is going to be these are lofty goals to do in these timeframes, and it's a lot of work in the midst of a pandemic that, while we're relaxing standards and things, is still actually going on, and we have a workforce crisis. So we just say that with the acknowledgement of all the challenges. But this is our hope and dream around the timeline.
Chelsea, I don't know if you saw in the chat, there's a question about why is it cut off at 20 when, in the YSIPP, we work with 24 and under?
Mm-hmm. That is a great question. I think what we've been doing is we do a lot of work with the children's systems, so not just behavioral health. And many of the other children's system, including education, go through 21. So child welfare, education, and the Oregon Youth Authority. So we're trying to be more congruent across the children's system. We know developmentally it makes more sense to go to 25. A lot of our other programming does. But for a lot of these services, we're trying to match our children's system partners. So that's the short answer. Yeah.
Were there other questions in the chat box that we might want to address before we have about 5 minutes left?
David, are you still on? David used to be chair of the Alliance as well. So he knows our work really well. And I guess, David, I just wanted to ask you to speak to why, we're spending all this time thinking about this. Why does this matter so much for us in the particular space of thinking about suicide, right? It's thinking about all the mental health crisis stuff. And I don't mean to put you on the spot, but I'm putting you on the spot of just, really want us to be sure that we understand why this is so central to the work we're doing.
Well, thank you, Annette. And I want to understand, I do want to say it is a component, right?
Yeah.
Like, I don't believe in crisis lines as the solution to suicide prevention by a long, long, long shot. We're there when people get to that point where they need to talk to somebody, they don't know who else to talk to. Honestly, a lot of times they are at a place where they have the means available and they are seriously considering it on that day. But what is really important about 988 is that it is shorthand also for these other things. Like, if we could get MRSS there before a kid gets to that place where they're contemplating suicide, that's the ideal, right? So maybe they call 988 because not only is it now a suicide prevention line, but it's a behavioral health crisis line that's a 3-digit number and really easy to remember. So everybody knows where to call, and they find out that MRSS is available to come out to their house and provide these services, and hopefully they never get there. So it's a component and an important component, but I think it's these other services as well. And just again to say that, everything with the Alliance is doing around the YSIPP and everything the state is doing around the YSIPP, it all comes together because there is not one solution to intervening or preventing a suicide. That's what I would say to it.
Thank you for that framing. I think that's really helpful. And just as a reminder, or actually people may not know this, right now where we're talking about 988 MRSS at the level of committee work in the Alliance is in our Transitions of Care Committee, which is led by Charlotte Lumley and Joseph Stepanenko. It's a great committee. And they are just beginning to dive into some of thinking some of the work around this.
I also want to just kind of call out it's 12:26, and I know that we said you could go till 12:30, but I want to make sure that if folks have any time for a few verbal questions, that we can ask those before we close the meeting down at 12:30. So do folks have any questions that haven't been asked to Chelsea, David, Cheryl, Beth?
I have a question.
Maria, go ahead.
Yeah, so just hearing about MRSS and going and meeting youth or young adults or families where they're at in the home, is there something in place then if there's abuse involved, things like that, where the home isn't the safe place, or what kind of procedure or systems in place for that?
Yeah, great question. I mean, keeping employees who are doing this work and families are equally important, right? And so we are working with 988 to figure out also, like, how do we triage the calls, what questions are asked, and how are those decisions made, whether it's safe or not to respond. As an individual, we are going to send out 2 people teams. So that has been decided that nobody will be going out alone. That there will be 2 people response. And then also we are working on connecting back with what's our relationship between MRSS and police system, and how do we keep that open, those open lines of communication if we do find yourself in a situation that we know what to do, right? And we know what steps to take in those crisis situations. So it's kind of like every single level we're assessing safety, from the time the caller calls to even going out. We also, it's community based. So it doesn't have to be in somebody's home. It can be at the park down the street. It can be out in the front yard. It can be, wherever we want to meet the family where they're at and where they're most comfortable as well.
Yeah, that helps. And that my thought is around also with protecting the youth in the situation where they aren't feeling safe with their own family kind of situation.
Well, that's the cool thing too, is anyone can call 988. And so we have the Lines for Life has already shared with us that they've seen an increase in kids, youth, young adults from 9 to that they're picking up the phone and already calling some of the Lines for Life. And so a child could call when they're in crisis and be triaged, or like say a teacher or a parent could call if they're worried about their child. Part of the customized training that I keep referencing for the people who are responding to youth and children, part of that specialized training that we're recommending is really knowing how to engage families, how to do crisis and safety planning that includes families. How do you make those judgments? So that's some of the things that have come up when we think about what is different about safety planning and about training from working with, like, say, a 60-year-old versus a 9-year-old in their family.
Okay, folks, it is 12:29, and I know that folks have more questions, but what I would encourage folks to do, if you have not attended one of the community conversations, they are really helpful, really informative. Would really highly recommend folks. Chelsea did put that information in the chat, so please attend one of those. You'll get a lot of information, super helpful. So I want to thank David, Chelsea, Beth, and Cheryl for presenting on 988 for us. I know it's a lot of information and we're all trying to figure it out. So I'm sure many of us will have more questions.
And Rusha.
And Rusha, sorry, Rusha, yes, and Rusha. So thank you to our presenters and to members and affiliates who have attended today. Thank you so much for being a part of this amazing team. We're doing great work. Thank you for spending your morning with us. And we will see you very, very, very soon. So have a great day.